Welcome to the Golden Hour, the podcast community where moms and moms-to-be hear stories from other mothers and top experts in the pregnancy and postpartum care field. You can visit goldenhour.fm for more information, resources, and all other episodes. You can also find us at goldenhour.fm on Instagram for comments and questions. Welcome, everyone, to today's episode of The Golden Hour. I am your host, Dr. O, and I have the honor of being joined by Dr. Rachel Yang. Rachel attended Wellesley College and the University of Pennsylvania School of Medicine. She completed an internship and residency in general surgery at Stanford University, and she completed her breast surgical oncology fellowship at University of California, San Francisco. She is a certified lactation counselor and an international board certified lactation consultant. She currently works at Marin Health as a breast surgical oncologist and a breastfeeding medicine physician. She lives in Berkeley with her husband and 2 children. Welcome, Rachel.
Thank you so much for having me. Really excited to be here today.
As I mentioned in the pre-show, I always love these blurbs because I'm impressed by everyone that I get the honor of interviewing. And then you yourself, you have a wall of impressive plaques behind you. So for everyone who's listening, if you can't see, if you're not watching on YouTube, Dr. Rachel Yang is quite impressive. So says the wall behind her. And so you will know certainly as we keep talking. Rachel, I was very, very excited to have you on the podcast for many reasons. And I've had the honor of actually having you talk with our OBGYN department at least twice, if not 3 times over these past couple of years. And the most recent time, every time I sit down with you, like my mind is blown. Like you are someone who obviously has a lot of expertise in the breastfeeding and breast health space and are really motivated to share that information, not only with us as clinicians, but in platforms like this with the patients and clients who get to listen. Because I think there's so many misconceptions and mistruths out there. And so I'm excited to have you on to really kind of speak the truth and correct some of those misconceptions that we all have had in the past and hopefully won't have going forward.
Yeah, well, thank you for having me. Just love talking about breastfeeding. So
yes. It's your jam. It's your jam. In addition to the surgical oncology care that you're providing, the fact that you've created this niche is just we're so lucky to have you in our community. It's such a valuable resource. But speaking of which, can you tell me more about your interest in breastfeeding and how you've kind of mirrored that with your expertise as a breast surgical oncologist? How did you be?
Yeah, I mean, I sort of went to medical school already interested in the breast at large. Like I came from a community and a family of a lot of people affected by breast cancer. And so I showed up knowing I wanted to work in the realm of breast cancer. And it took me not too long in my first year of medical school to know I wanted to be a surgeon. And so there that was. And then, how I got to breastfeeding medicine was a bit different. So I, started my general surgery residency at Stanford. I went through most of my training with just a very clear path to get to breast surgical oncology, where I'd always thought I would land and still very much am involved in that world. But I had my firstborn in my chief year of residency. And my firstborn had a real complicated birth. We had a complicated pregnancy. And then we, not surprising, had a complicated time breastfeeding. And he was in the NICU and had all sorts of challenges that occurred to me as someone who was soon to be a breast surgeon. Shocking how little information there was out there that I could grasp and hold on to, and how much conflicting evidence there was in the community, on forums online, even in the physician group, Dr. Milk. That's a breastfeeding physician group on Facebook. And that made me feel really motivated to do something with my profession beyond the more classic breastfeeding focus, but to also see if there was a world where having some specialty in breastfeeding and helping others with problems similar to mine and problems unlike mine could have a specialist to really improve their medical care and improve their ability to have a real special breastfeeding relationship. For me, it ended up being that breastfeeding was just the most core, fundamental, and healing experience of my pregnancy and postpartum time with both my children, but really with my first, who had such a tough go. Yeah. And I wanted so much to share that with other people. and to be able to be thinking a lot in my professional life about what's gone wrong in the medical system where breastfeeding's become so challenging, and why even as a soon-to-be breast surgeon, it felt really impossible to make it work. And so that's what led me then to kind of heard through the grapevine of Katrina Mitchell, who's well known in the field, who's a breast surgical oncologist and a breastfeeding medicine specialist. And I actually just sent her like a cold text through her patient portal asking like if I could talk to her. And then she started mentoring me. And then I went down the rabbit hole and became a certified lactation counselor, IBCLC thereafter, and then figured out how to incorporate it into my practice. And then now it's really become the focus of my practice.
Yeah. Yeah. I mean, thank you so much for sharing. It's not uncommon where sometimes like the difficult challenges that we overcome are what actually inspire and motivate us to, find like our next path. It sounds like you always knew that you cared about the breast from your personal and community experiences, and I can only imagine, goodness girl, like chief residency year is really hard year for us OBs, but let alone for general surgeons. And so I can only imagine like what you already had going on in your life academically and professionally just as a resident, but let alone the experience of pregnancy, postpartum, and then it sounds like difficult times around your delivery and postpartum. And so to be able to take that pain and turn that into something so positive you've paid forward to patients is amazing. It truly is. So grateful that we're going to have the next hour or so to talk more about it. And I want to think back to something that you said, that you had asked this question, like, what has gone wrong? What has gone wrong in kind of the space of breastfeeding medicine and lactation that you kind of see it, how we kind of approach lactation and breastfeeding support in pregnancy, postpartum, and what have you learned along the way?
Yeah, it's such a big topic, and I could probably talk for 2 hours around just this question alone. So I'll try to keep it somewhat brief. I think so much is cultural, social, psychological. And unfortunately, like the main thing is we've lost our village. And because we've lost our village, we've lost our communal, inherited and socially supported ideas around breastfeeding. And we've lost the ability to share that information readily among one another and support one another. And so what's replaced it has really been a medicalization of a very physiologic process, of a process that's actually the defining feature of mammals and has been around for so many years. It's hard to even imagine, and is the real like fundamental way that the breast is meant to be in its physiologic state. And we know so much about breast cancer and about pathologies, pathologic states of the breast, but the medical system, the community in general knows so little about what is the breast intended to do. Instead, it's really thought of in a pathologic lens. And I think that comes through with how the breastfeeding world works, really thinking about what's wrong and not thinking about what's right. And that for so long, breastfeeding has worked well for most people, not for everyone, but for the vast, vast majority of mother-infant dyads, long before the introduction of pumps and formula and westernization and capitalism, like we could do this. We can't now. And I think so much of that's because of what's really changed in our society.
Yeah. I mean, this theme comes up so many times on this podcast so far, but this concept of the village. And when I think of my role as an OB, and so much of what inspired this podcast was really truly feeling like the healthcare was this kind of modern structure to help recreate the village. But the healthcare system, as you know, as a fellow physician, is so fractured and so imperfect and too big to actually serve that function, that when we traditionally lived in a literal village surrounded by, siblings and family members and community members, that we were constantly just seeing babies being born and people feeding those babies. And it was just something that we were naturally entrained in, versus now there's like a lack of that fundamental knowledge because we live in kind of these little isolated microcosms. The system we created to fix that, to fill those gaps, can't do so sufficiently unless there are people like you who are, again, spreading the good word and trying to correct some of those misconceptions that we have. And I think I also recognize that, for me as an OB, one of my there's a lot I know, but there's a lot I don't know, like any good, humble human. And that a lot of that is around the space of breastfeeding and lactation that, when I think back to my OB rotation or my OB residency, I want to say that it was like, there was one talk my intern year that one of our midwives gave about breastfeeding. That was the one talk I got. And so here I am having the honor of caring for, so many postpartum people in my actual practice. And I don't know nearly as much as I want to know, but it also sounds like the breastfeeding and lactation community is also kind of at a place where we're continuing to expand what their knowledge is. And I love what you kind of harped on, which is that we know a lot about the pathology of the breast. Like I know enough as an OB in terms of kind of what to refer my colleagues or my patients to in terms of a breast specialist if there is a concern about a breast mass or even potentially a malignancy. But normal breast physiology is something that I didn't even really think about until, again, I had the honor of having one of your talks. And so can you kind of tell us more about like the breast as it is in terms of like kind of the normal physiology of the breast and its function? I think something that you taught us, it's been oftentimes thought, rather than thought of as a gland, it's been oftentimes thought as like a different type of breast tissue, and what that means, and how kind of in simpler terms for someone who's listening who's not necessarily a clinician, how to think about the breast in that way.
Such a great question. And I think right away about like, can you imagine a medical field where we like understood uterine cancer, but didn't understand the development of the fetus in the uterus? Or can we imagine like understanding, diseases of the bladder without how urination works, or, peeing, medical word. And so I think the same is true with breasts. Is like, you can open a medical textbook and there are pages and pages about benign tumors and malignant tumors like cancers and rashes of the nipple and all of these things that are pathologies. And there's really nothing about like the very basics, which is lactogenesis, which is the word for production of milk, or how does milk get made by the breast organ. And that you can only find like deep in a lactation consultant textbook. And what lactogenesis is the first phase is the breast preparing to make milk. And that happens during all of pregnancy, stimulated by the hormones of pregnancy. And then it goes into the first few days postpartum. And when you see the colostrum being made, sometimes people have colostrum leakage during pregnancy, and that's droplets coming out of their nipples, or even more leakage in some women. And other times it's really just starts right after the baby's delivered. So that these first moments of milk being produced is that first phase of lactogenesis. The second phase happens from around the second day postpartum into 14 days postpartum, around there, where the breast is now learning to make milk. So now we're having an upswing of milk production. You're starting off with drops, and then you're slowly transitioning from colostrum to mature milk. And then lactogenesis 3 is that mature phase of milk that women can stay at for years. Mm-hmm. After they've delivered. And that's the life cycle. And then I should say, so after lactogenesis stage 3, there's an evolution of the breast whenever a woman weans. And so you go from these active secretory cells that are making milk to no longer making milk. And that's a different phase. The breast looks different, it feels different, and of course isn't making milk. And it's just remarkable how little research there is on all of that, like why in some people these stages of milk production don't happen as they should.
Yeah.
And yet almost every other part of the body, we really understand it in great detail in the medical world.
Yeah. Yeah. I know when I think about what you just said, and I think about why we don't understand it as much, and why isn't there nearly as much research, it goes back to something that I was speaking with another women's health provider about earlier today, is that there's all these disparities in women's health. And even when it comes to like the research that's done, is that how come that those topics of breastfeeding and breast health and normal breast physiology, why isn't that considered interesting enough to get as much grant funding and as much attention and focus? It makes me think, it makes me ponder. And we won't have that answer that question today by any means, but I think I have a question that you can answer more simply. What would you say in your practice are some of the most common breastfeeding issues that are challenges that new moms face, and that you maybe see pretty often or more often?
I think that what I see the most of and the most complications related to, especially those requiring intervention or procedures, are those related to oversupply, which the medical word is hyperlactation, often created by pumping or other things, but mostly pumping. And then I see the other end of the spectrum, which is not enough milk being produced. So I think I see, and that's called hypolactation, low supply. I think I see the two ends of the spectrum because that's where you see the most opportunity for medication or diagnostics to understand why something's not going as it should. And the most opportunity for intervention. But I see, all sorts of odd ends in between those two and things that have nothing to do with the amount of milk being produced. But it seems that a good number of my referrals, the vast majority, are related to too much or too little milk.
Yeah. Well, that's a good place to start. So it sounds like you said that one of the more common causes of overproduction is breast pumping. Can you speak more to that and, how someone would approach that?
Yeah. So oversupply is defined by the breast making more milk than the baby needs. So the supply and demand are not meeting up. And that trigger, the stimulus for the breast to be making more than a baby needs, is often the usage of a pump. Because you don't have that. And again, coming back to that, my belief that what's really missing in most of our approach to breastfeeding is the trust and the focus on the natural physiology. So where you need the baby in a breastfeeding relationship to request the amount of milk that it needs. And you need the baby to drive up supply when the supply is not big enough, or to drive down supply when the supply is too big. And when that human is replaced with an electronic device that's pumping a breast, the body does not respond in the same way. And a pump can, all sorts of advice exists out there to use a pump for X number of minutes, as if us humans are an equation, and we're not. 15 minutes, 25 minutes, whatever is being recommended is not the same for one woman or another. One woman pumps off, 4 ounces in 2 minutes. Another woman takes 40 minutes to do that. Not that you should ever pump for 40 minutes, but every body is so variable. And so to hook up a pump and just turn it on and turn it off at a given number of minutes, that is error number one, to not be thinking about how much does my baby need. So if your baby is going to be drinking 3 to 4 ounces, the pump should really only be producing 3 to 4 ounces. It shouldn't be driving you to produce 6, 7, 8 ounces just because you can. I mean, I think this is also a cultural piece of it as well, where the problem is not just the interruption of natural physiology. The problem is what has social media done for this world and what have our devices done, which is photos being circulated of freezer stashes of milk filled to the brim, and people having a real awareness that some women make excessive amounts of milk, and then the desire to overachieve in that way. And how so many women, especially when the brains, I think, in the postpartum state, are really turned on to the idea of how do we succeed? And I think evolutionarily we're meant to want to keep our babies alive at all means possible. But that sort of drive to do everything as good as we can with our newborns gets funneled into breastfeeding and then into pumping, which creates this real pump culture, I like to call it, that's driven to encourage women to make far more than they need to. Yeah. And even just an excess of 5 ounces a day can be a real problem for a lot of women. So I always tell people, if you're putting more than 1 ounce a day into the fridge or freezer after the baby's drank all of the bottles for the day, that's too much. 1 or 2 ounces, that should be enough. And that can build up a small freezer stash over many days. No one needs a huge freezer stash. What we need is to focus our time and energy on making a breastfeeding relationship healthy and functional and gratifying for both parties involved. And then supplementing with pumped breast milk if there's a separation between mom and baby, or if there's a need to pump, different from what we're talking about here, where normal physiology is possible. But there are times where there is a need to pump because a baby's in the NICU. I've been there. Yeah. There needs to pump when a mom's returning to work. But when a mom and baby are together and the breastfeeding relationship is working well, my goal is to focus on how to make that work at its best capacity, and to either get the pump totally out of the picture or only use the pump if it's necessary. Yeah, that makes total sense. And goodness, you really struck a chord for me, because one of the reasons why this podcast exists is because I do think that social media, as
as beneficial as it can be in terms of creating community and helping patients kind of access different ideas and concepts they wouldn't necessarily normally have to, I think there are a lot of personalities and people kind of projecting either ideas or imagery on social media that adds to the inherent pressure that all of us already have to either achieve or get a certain amount of, for example, your example of like the pump culture of like a certain amount of freezer bags and the milk in the freezer, or looking a certain way 3 months postpartum, all of these things that are unnecessary pressures that also aren't actually factual. And I think any kind of space that we can create to, number one, empower women or birthers or postpartum people, but also just give them information that is factual and helpful and truthful is my goal as a clinician, as is yours. And so it's really kind of helpful to be able to contrast that and say, hey, those images, those personalities, that's something that's specific to them, but maybe not necessarily the thing that everyone needs. And to go, I think you alluded to when pumping is beneficial or needed. So transitioning back to work or separation of mom or baby, especially if the baby's in the NICU. Any other examples that you see are good uses of pumping?
So sometimes there are babies who can't transfer the milk, meaning the milk is there, but the baby can't get it into their mouth, whether that be from underlying illness. Reflux is one where babies often kind of top out at a low volume. They're too uncomfortable to keep driving the milk in. Tongue ties, it's a hot topic. But there's also just the infants that for unknown reasons aren't transferring well. And a lot of times those are small babies or babies that were born preemie or late preterm, and take some time to figure it out. And then lastly, there are women who haven't driven up adequate supply, and for whatever reason their supply is low. They might do a few weeks, and in my practice I usually say limit it to a few weeks of triple feeding, meaning pumping and breastfeeding, to try and boost their supply and see where they can get to.
Yeah, that's really helpful. And kind of on the other end of the spectrum, thinking about women who have low supply, what are some of the common causes of low breast milk supply, and how do you approach patients who are dealing with that?
Yeah, I would say the most common cause of low supply is idiopathic, meaning we really don't know. We don't have a clue. Unfortunately, there are some people doing research in that realm, which I'm really excited about. And I think we'll eventually figure out that the causes are likely multifactorial, genetic. You often see twins with similar experiences around this. And probably something else happening environmentally that we have yet to understand. But for causes that are known, women who have low thyroid function, that can absolutely affect it. And women with PCOS, the testosterone levels can inhibit lactation. Various medications can, some of which are taken by accident. So certainly like medications such as, Sudafed, Benadryl, those can inhibit lactation. There are various opinions about this, but a good number of anecdotal experiences with estrogen from placental encapsulation can affect and inhibit lactation. Just like high estrogen states inhibit lactation, such as pregnancy and estrogen-containing birth control pills. And then there's, for whatever reason, an unclear association with women who have a difficult time conceiving.
Interesting.
That there seems to be something around signaling pathways and hormones that the correlation seems quite great between a need for IVF and low supply. And then lastly, diabetes is absolutely related. And for some women, treating the diabetes can help supply improve as well. But, 99 out of 100 times when I see a woman with low supply, we don't have an answer to it, unfortunately.
Yeah. And I think that for me as an OB, that's commonly a point of frustration appropriately for a lot of moms, is kind of dealing with that low breast milk supply, because there is this like onus of like, this is my baby. I'm meant to feed my baby. Me being a successful mother means I'm feeding my baby. And so when the breast milk supply is low, it sometimes is tied in with identity and feelings of postpartum depression and anxiety. And it really is complicated. And I'm sure you sit with many women in that space. How do you help your patients, your clients who are dealing with low breast milk supply? What are some of the kind of resources that you give them? And how do you kind of encourage them through that state?
Yeah, it's an incredibly challenging experience. I think there is just tremendous grief that women go through around this diagnosis of low supply. And it's really where probably the most postpartum depression pops up, is like in these scenarios where there is an experience around breastfeeding that's far from what one was hoping for. Mm-hmm. And a feeling of inadequacy, and a lot of old trauma can resurface here, a lot of feelings, interpersonal challenges with a spouse, but this is just a huge realm and need for support. And so a lot of what I'm doing is really just holding space for it and thinking about how their mental health is doing in light of this diagnosis, thinking about if they need referrals to therapists or psychiatrists, providing resources to some of my favorite books around grief and breastfeeding, resources around milk donation, milk banks, and then really talking to women about what their goal is. And I think that I certainly am biased in that the women I see who find the most rewarding experience in producing milk is around those who are directly breastfeeding and not pumping. Yeah. Even in light of this diagnosis, because the pumping, I think, can often be re-traumatizing to see. I only have a few drops come out, and can be a lot of effort for not the experience of someone who's maybe exclusively pumping and producing a ton of milk and getting that gratification. To exclusively pump is incredibly challenging. I mean, it's beyond one of the most difficult things to be, hooking up to a pump this many times a day. And then on top of that, to see little milk production. So I really try and encourage these women to focus their time on direct breastfeeding. And I think that's contrary to a lot of advice to pump more when you have low supply. And if you have a baby who can stay at the breast and get the milk out, even if it's small amounts, there's no reason to believe that the baby is not going to stimulate the mom more than the pump. And even sometimes you see a baby and a mom come back where the supply rebounds quite a bit when the pump's removed from the picture and they're just direct breastfeeding, because they're getting more of that hormonal stimulation from all the skin to skin and all that happens. And so I think a lot of my time is spent re-educating that there are women who make, total combined in 24 hours, 1 ounce of milk. So drops, we're talking for most of the part, are just cc's. And they can love breastfeeding, and they can go on to breastfeed till their babies are 2 or 3. And when they're nursing their toddler, no one has a clue that they ever had low supply, because it looks so natural and with ease. Yeah. And does it work for everyone? No, there are some babies who get frustrated with the low supply. And so the caveat that it's not always going to work. But I find the women that are just focusing on the breast really around for reasons of comfort and bonding, when the supply is low, then the baby starts getting some milk and enjoying it, and they tend to start nursing much more frequently. But the baby's going to the breast primarily for that connection that's happening emotionally, just like, babies nurse from non-birthing parents, and it doesn't have to always have much milk for it to be a really bonding, enjoyable experience.
Yeah.
And it doesn't have to be a lot of milk for there to be benefits from antibodies. I think the data doesn't exist, like at what level there's benefits, but there are absolutely antibodies, even with just a few milliliters of milk.
Yeah. Well, I definitely will ping you after this episode recording to get the list of those resources. You mentioned the books on grieving with breastfeeding and any other resources, because I think that being able to point patients to the direction of resources like that can make a really big difference when, again, you're already consumed with feeling so bad within yourself. But I think knowing that there are others who experience this, and let alone just normalizing that experience and making sure that people feel like, even the small amount that you're giving your baby is beneficial for that lactating person and the baby that's getting that. So really good to spread that love and encouragement around. So I'd like to take a moment to tell you this is my passion project based on years of experience as an OB/GYN doctor. I aim to empower moms and moms-to-be and those in the pregnancy and postpartum care space. If you appreciate what I do, please take a moment to like, subscribe, and share with your friends so it can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, suggestions, or questions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Now I want to kind of shift gears to something that I've really enjoyed whenever I've had the honor of listening to you talk to our group is what I would call your myth busting. I know there used to be like a show called Mythbusters, and in my mind, Rachel Yang is my like breastfeeding myth buster. Like every time I like leave a meeting with you, I'm like, what? Like mind blown, like literally the emoji with like smoke out of my head. So what do you think? And I know it's a long list, which is why I'm so excited to have you on. But what would you say are the kind of the most common myths around kind of breastfeeding?
Yeah, and I'll give credit to Katrina Mitchell because she introduced the word mythbusters on her website, which I love, physicianguidetobreastfeeding.org. But I think the number one is probably yeast. The idea that yeast is a disease state in breastfeeding moms has really been debunked. I mean, there are countless research studies now, and just mostly in the last 5 years, showing that in women who are told they have yeast of the nipples, these women, number one, are given alternative diagnoses such as vasospasm or nipple blebs or Demer's, dysphoric milk ejection reflex is what it is, and treated for that, and the symptoms go away, which is usually nipple pain or whatever, nipple burning, nipple pain. And there's a remarkable study where a scientist and physician biopsied women's nipples and also cultured breast milk for people who had been diagnosed or, I shouldn't say diagnosed, but told they have a diagnosis of yeast, because it really is not medical diagnosis anymore. In breastfeeding moms, that is. And these women didn't have any yeast present in the tissue of their nipples nor in the breast milk. And to make very clear here, infants do get thrush. They do get thrush of their oral cavities, and that's a real diagnosis that needs treatment. Defer that to the pediatricians on when it needs treatment and when it doesn't. But it doesn't transmit the way that a yeast infection in a woman, a vaginal yeast infection, doesn't transmit to her sexual partner. Or usually doesn't. And similarly with the mother infant, you really don't have to worry about yeast or thrush, synonymous, in the infant's mouth transmitting to the mother. And so all of the successive treatment of so-called thrush or yeast has been really damaging to women, because medications are not only further affect the microbiome and the healthy flora, just like in the gut, we have a flora of our breast and in our ducts of the breast, that is really affected by these medications. And women are often given oral medications, which are pills, or they're given topical antifungal creams. And furthermore, those antifungal creams can cause reactions, can cause allergic reactions, and that can make nipple pain even worse. So we get on this spiral of nipple pain and treating it and then making the nipple pain worse. And unfortunately, it's just caused a lot of harm to women to be treated for a diagnosis that doesn't have any evidence as such. And this is a real good example of how in the breastfeeding world, there's a lack of adherence to what's evidence-based. And not even that, there's been a lack of demand for evidence. So in all of the realms of medicine, no one just prescribes medication here and there. We know from X number of studies that this is when you need antibiotics for pneumonia and X, Y, and Z. But in breastfeeding, no one demanded that. And we were giving medication for something that was never proven.
Yeah. No, I think time and time again, how many patient messages I get on the My Health Online. Hey, just saw my pediatrician, baby has thrush. Can you give me, I need treatment for my breasts. And even without symptoms, right? And so some of it speaks to like also educating our pediatric colleagues who are oftentimes the ones who are diagnosing the thrush and probably sending those moms back to us, let alone the education that we can do amongst ourselves and amongst patients. And speaking to something that you said that, very commonly we used to try to treat yeast infections of the breast because someone would present with breast pain or nipple pain. What are some of the more common causes of breast or nipple pain, and how should we approach those symptoms?
Yeah, I think vasospasm is the most common thing that I see causing nipple pain. It's where the blood vessels get very tight at the level of the nipple. And there's some thought that it has to do with how estrogen affects reactivity of blood vessels in the body, and how the sudden drop in estrogen postpartum can cause more vasospasm. It's similar to vasospasm of the hands, the fingers and toes, called Raynaud's, which is where people's fingers and toes turn kind of white and then become blue, depending on who you are. Same thing happens to the nipples, where they become white, blanching in color, and then turn back again to either blue, purple, or pink. And it can be very profoundly painful, because as the blood vessels constrict down and tighten, they're losing blood supply to the nerves, and the nerves generate major pain signals that can create a lot of the burning sensation that people previously would associate with thrush, and can do a lot of the radiating pains that go from the nipple deep into the breast, because those nerves are like a spider web from the nipple all the way across the breast.
Yeah.
And that often can be treated with behavioral modification. I love wool nipple pads, like little sweaters for your nipples, can keep them really warm. Thinking about keeping the temperature up in the house, doing a lot with what you're wearing. A lot of people notice triggers right when they step out of a hot shower into the cool air. So to have a warm towel ready, and just applying heat indirectly over the clothing after breastfeeding can do a lot. And then there are women who have remarkable benefit from medication called nifedipine. That's a calcium channel blocker, and it is unbelievably helpful in many cases.
Yeah. Yeah.
And even just really a few weeks of that medication sort of like retrain the nipples on how to preserve blood supply.
Yeah. I was going to ask, how long would someone need to be on that nifedipine, but it's not long term. It'd only be kind of for a couple of weeks.
It depends on the person, anywhere from 2 weeks to the whole time they're breastfeeding, but most people are around 1 month.
Yeah. Yeah. Okay. My other favorite myth that I alluded to early on when we were talking about kind of the normal physiology of the breast was kind of treatment of mastitis.
Mm-hmm.
This was probably I still remember your talk. It was probably a couple years ago, but our group has totally changed how we approach early mastitis, how we counsel our patients. I get excited every time I get to teach a patient this new concept. Can you, in your own words, kind of address that kind of the treatment of early mastitis and how we should think about it?
Yeah. And I feel so lucky, to live in a community where information gets brought in and taken up really well, because I even forgot that was a myth, because it's now everyone in this part of the Bay seems to be really incorporating the new mastitis protocol. What I'm referring to is the Academy of Breastfeeding Medicine released a new protocol on mastitis in, I think, 2022 that mentions all the things I'll talk about here. But, when I was breastfeeding my first, and I guess still a lot of people are hearing this advice, that is, if you have symptoms of mastitis, to do heat and massage and pump more and try and get a clog out. And really the opposite is true. So when we understand that the breast is like a gland, it's an endocrine organ that is oftentimes overstimulated, and that overstimulation by pumping or too much milk production leads to a state of inflammation, which is mastitis. And we understand that mastitis almost never is infectious, and very, very, very often in a very profound inflammatory condition. Then we think about it differently, which is that we don't want to overstimulate the gland. We want to, if anything, drop that to very normal or even lower stimulation. So when you have mastitis, one of the worst things to do is start trying to pump or breastfeed more, because then you're sending in more signal to the breast to work harder. It's like taking a pancreas in someone who's an alcoholic who's got pancreatitis and telling them to drink more. It will be a terrible situation. And people with pancreatitis, which again is an endocrine gland similar to the breast, and it's been overstimulated by too much alcohol, causing pancreatitis, they're told to rest. They are told to sometimes not eat for some days and brought into the hospital for not for antibiotics, although it used to be the case that it was treated with antibiotics. The breast inflammation of the breast is similar. We really want to rest the organ a bit. And I don't mean to stop breastfeeding or to stop pumping, but to do what's normal physiology and what you were doing previously. If you were pumping 7 times a day, stay there. Don't go to 10 times a day. If you were all direct breastfeeding, don't add in the pump. And then to treat it as an inflammatory condition, which means using anti-inflammatories, which is mostly ibuprofen at dosage that are often more than you would take just for a headache, but use the ibuprofen at maximal dose prescribed by your provider to treat the inflammation. And then instead of heat, to use ice. Think about a sprained ankle. We apply ice to it because it's swollen, it's painful, and the ice is what decreases that swelling. We don't usually apply heat to a sprained ankle. And so similarly, this is an overused, inflamed part of the body. And then lastly, massage. That's one of, I think, the worst myths out there, that somehow massage is going to help a part of our body that's already hurting. It not only like pushes on really fragile tissue and can lead to the milk ducts even having injury, where milk leaks outside of the ducts and causes a collection of milk or causes an abscess to form, but it's painful and it can cause more edema, which is swelling, and that can cause further obstruction or blockage of the milk coming out. There's, I think the myth also is that a plugged duct is a stone in a duct. This idea didn't stem from any medical experiment, but just kind of a notion that because there's ducts in the breasts and the milk's not coming out, well, it must be that there's a blockage inside the duct. Well, we really understand now what's happening is that there is so much swelling. The ducts, which are usually large, are becoming collapsed in and real tight from all the swelling on the outside. And so the milk's not getting through easily, not because there's a stone, but because they're really compressed from the outside in. And so to alleviate that, we want to help decrease the inflammation, not try and squeeze out some sort of stone, which isn't there.
Yeah, yeah. And you're right. I think there has been like a real uptake in our community and probably kind of larger communities of those who care for postpartum persons around this kind of this new model that came to be in 2022 of approaching early mastitis and understanding that it really is an inflammatory response of an overproduction of a gland rather than a true acute infection, or even for plugged ducts, there's not like actual blockage versus just the inflammation of the tissue around it. But I still find that the people who need to hear the real truth are our patients, and hopefully whoever's listening right now, because I still find that, when patients will call in with symptoms or messages with symptoms or come to the office, they're still mentioning the things that were probably passed down to them from those who didn't know better. So glad that we're talking about it right now. And then another big myth for us to bust that you alluded to earlier is tongue tie. Rachel, tell us how you feel about tongue tie. I know it's complicated.
Well, I would say that, to not get ahead of ourselves, I wouldn't call it a myth. I would just call it, I'd say there's a misuse of the term.
Yes. Good call out.
The frenulum, which is the connection between the floor of the mouth and the tongue, is a normal anatomy, part of our anatomy, and it's there for everyone. There's a connection there. When people say, my baby has a tongue tie, it isn't really a great medical word, because the question is there a functionally limiting restriction of that frenulum? Is it so tight that the baby's not able to move their tongue in healthy ways? That's true. That happens. And then there's a lot of times where it looks real tight, but the baby's moving their tongue great, or it doesn't look all that tight, but the tongue can't move great. And so most of the assessment tools around tongue tie incorporate both function and anatomy, and you really have to think about them together. It's not just a visual inspection of the tongue and saying you've got a tongue tie. And I think that's where it goes wrong. Just to see these charts showing how the supposed prevalence of tongue ties has just incredibly skyrocketed in an exponential way in recent years tells us that there's an overdiagnosis problem happening here. And to hear that some practices see that half of the infants are diagnosed with tongue tie, there's just no way that in a species that's survived for so many millions of years, that half of us were born with something that was really pathologic. So I think we just have to think real critically about what's going on here and understanding that there is a big business around this. And this is where the problems of capitalism come into play. There's a lot of money to be made in the tongue tie industry, and there are people who are doing a great job in the industry and in the field thinking about who needs a tongue tie procedure done, and there are people who aren't doing a great job with it. And I think to just be real, coming at it with a critical eye, and much more often than not, I find that there's another problem at bay that needs to be diagnosed and treated. And when that's treated, the concerns about tongue tie wash away. And that we often jump to it because I think in our world of wanting answers quickly and wanting to do, we also love the idea of being able to cut something and have it be done with. And when oftentimes there's something else totally going on. So, there are times where I'm worried, where there are wounds that aren't of the nipple and they don't look normal, or there's a baby who cannot get the milk out, and even though they're trying. That's when I really rely on my specialist in ENT to help me with looking at a difficult tongue and seeing if they need a procedure. But I do think in general it's way overdiagnosed.
Yeah. So that's a great segue, because my question as an OB, because we don't make this diagnosis ourselves. Who would a patient go to see if they were concerned that potentially they weren't having appropriate milk transfer because of tongue tie? Is that something that their pediatrician assessed and then refers them to an ENT? What does that look like?
Yeah, it can happen through a variety of routes. I certainly refer to an ENT if I have a real concern. Pediatricians can. There's certainly a lot of lactation consultants referring to various providers in the field, whether that be pediatric dentists or ENTs. But I think always, instead of self-referring, I think starting with someone who has a more broad perspective to see what's really going on here.
Yeah. And what are you, as a lactation specialist, when a mom is feeding with their infant in front of you, what are you looking to help you assess it's a good latch, that there isn't necessarily like a structural issue that needs like an ENT referral? What are you looking for?
Yeah, for me, it's less about, I'm looking at the latch, like how much areola are they pulling in their mouth? Okay. How wide are they opening their mouth? Does their suck and swallow follow a normal rhythm and pattern, which aren't all related to tongue ties. But I think for me, it's more about what's happening with what I call a weighted feed. So you weigh a baby, then you have them breastfeed and you weigh them after and you see how much milk they got. And if I have a mom who's able to pump quite a bit of milk, but the baby can not transfer very much, and I don't have another explanation, and I then look at their tongue and it looks restricted, well, then I'm thinking about it. Or if mom has really bad wounds and then I'm looking at the tongue and it's restricted, I'm thinking about it. Yeah. So it has to be a combination of a functional problem, whether that be wounds for the parent or a difficulty transferring milk, and then something where the tongue does have an appearance of looking restricted by the base of the mouth.
Yeah. Yeah, very helpful. Very helpful. Let me see. Another, whether it's a myth to be busted or maybe an overuse of a product, we used to oftentimes prescribe and have it made at a compound pharmacy, something called Apno, so all-purpose nipple ointment. Can you tell the audience kind of what that is, what it was formerly used for, and what the thoughts are now in kind of the breastfeeding space?
It's a great question. Apno is usually 3 agents: an antibacterial, an antifungal, and a steroid cream. And this is sort of like the idea of throwing the kitchen sink at it. And it's also a real unusual situation to have a place in medicine where so routinely everyone's prescribing like a 3-thing triple cream. Like, it's, I think, just really reflective of our lack of understanding of the breast physiology. And I very much feel that this is something that should never be prescribed. There is no evidence anymore for an antifungal. So that's the first thing that makes Apno really a thing of the past. And there's no evidence for topical antibacterials. So not only do many medical organizations say not to give topical antibacterials for a variety of other conditions, but there's certainly no evidence that it's of any benefit for nipples in lactating parents, because it's really thought to be the emollient component of the ointment or cream that helps with wound healing, that the moisture that allows for that healing by secondary intention, which is like healing from the base up of a wound. And that bacterial infections are so rarely the case in a breastfeeding person. Topical bacterial infections, that is, of the skin, superficial bacterial infections, and that those really are few and far between. And then when we routinely give things that are antibacterial or antifungal, again, we're changing the microbiome. So the one component of Apno that can be really helpful that I love prescribing is the triamcinolone cream. Yeah. So triamcinolone cream, or other formulations of steroid cream, is a topical that really treats inflammatory related pain and can work wonders for people that are in a lot of discomfort.
And how would either me as a clinician or a patient who's experiencing discomfort know that they should ask for a prescription for triamcinolone ointment from their OB clinician?
Yeah, and I'll say triamcinolone cream is my preference, not ointment.
Cream.
The ointment tends to be can clog some of the glands in the areola. But really, if the pain's something that feels intolerable, and I think for everyone that's different, and if there's not another cause for it. So I think it's important to be thinking, is this vasospasm? Is this something that you're allergic to is, a new soap or a new material on the breast. And in that case, if it's an allergic dermatitis, the steroid cream helps as well, but you also want to remove the thing that they're allergic to. But is it eczema? It can help with that as well. But steroid cream can be helpful for a lot of women, for a lot of various things. So I think if a lot of people think they need to suffer in silence, and I think instead bring it to your provider and see what they think.
Yeah. What are some of the, if someone's at home, when should they seek medical advice? Like what's something that might be happening to their breast that warrants them either calling their OB or asking their OB to refer them to someone like you? What would you say is on that list?
I mean, in my practice, I see everyone with, from the order of problems that have been around for a day that aren't scary at all to problems that have been around far too long that are terrifying. And I'm always happy to see everything in between. I think there's no harm in asking for help. When there's something that's unclear, like we as providers shouldn't expect our patients to be doctors themselves. And I think there's a lot of confusion out there about what's normal in the breast. So I always prefer early referrals, but just to say some clear things, like a lump in the breast that is even in a breastfeeding mom, that's not going away after a week or so. And I don't mean a lump with fevers and redness. If there's fevers and redness of the skin and that's going on for more than 2 days, it's time to talk to someone. But I mean, a lump that's really sticking around, we shouldn't assume that it's from breastfeeding. You can get breast cancer when you're breastfeeding. I think that's one of the most devastating things I see is when we say, oh, it's just a clogged duct, which, as I mentioned earlier, is a term to be contested with. But to say it's just a clogged duct and ignore something for weeks or months and then find out it's breast cancer later and we could have done something about it much earlier is a devastating situation. So not to put the fear in people listening to this, but I think we have to have a humble approach that, lumps and bumps that move, that are here one day and somewhere else the next day, or that grow and shrink, those don't worry me. But a lump that's not going away after a week should be evaluated by a professional.
Yeah. Agreed. And I think something that you have alluded to multiple times throughout our wonderful talk so far is that there needs to be kind of more research in this space. And there are some great people that you've alluded to already who are working to bust myths and push that needle forward. Are there any kind of that you're aware of as an academic, any new or resources or treatments in this space that you know are in the horizon or things that you're excited about?
I think there are a lot of wonderful organizations really committed to promoting breastfeeding research moving forward. And some of those are the Academy of Breastfeeding Medicine and IABLE. And at the same time, I think there's not enough focus on this kind of work, especially from our own professional organizations in the worlds of surgery and breast oncology as it relates to breastfeeding. So I hope that in the future, there'll be more educational and research efforts from these organizations that are outside the sphere of breastfeeding. And I also hope that there'll be more funding given to people who want to study things such as low supply or such as breast and nipple pain, or I think really an interesting space is like where maternal mental health and breastfeeding challenges overlap.
Yeah, agreed. You and I both see and have the honor of caring for patients who are really at some like emotional lows, but also I would say peaks in terms of, whether it's like depression, anxiety, frustration. There's so much that we already alluded to surrounds like the act of feeding and like the sense that like, I must do this thing, let alone you're carrying a weight of maybe it took years to get pregnant. Maybe you actually had a really hard pregnancy. Maybe you had a traumatic birth. And so just having a better understanding how mental health and feeding go together is something that I myself am very interested in and hopeful that will be an arena that will continue to be explored more. Yeah. I know that you made time for me in a already very busy clinic day. And so as we plan on wrapping up, are there any kind of words of wisdom or sage advice that you'd like to give to anyone who's listening, moms to be or moms who are in the thick of their postpartum, or maybe they're a couple years out, especially, not only as a breast health expert, but as a mom yourself, anything that you'd like to share?
Yeah, I'd say, trust yourself the most. And if something doesn't feel right, advocate for yourself to your healthcare providers. There's so much advice out there. And ultimately what works is what works with you and your child and your family. And for everyone, that is going to be slightly different. I think that's what's rewarding and also so hard about my job, is that there's no algorithm for this. And I think if someone is giving you an algorithm or acting like it's all that simple, then I would be suspect, because it's not simple. And, how you figure out how you want to feed or how you want to deal with nighttime sleep or all the different things that come into play as babies get older and feeding becomes changing and complicated, I think is really a matter of what's best for you in the context of your life, your professional world, your family and friends, and to just keep that in mind. And I think that the first 24 hours after delivery are just, we cannot emphasize enough like how crucial that is to getting the ball rolling in terms of breastfeeding. It's difficult when you have a newborn to hear a baby crying and not immediately think, am I doing something wrong? Is there something wrong happening with me? And I think that's where the village once taught us that all babies cry, and actually crying is a sign of health and vitality. And that those first days, actually, the baby's born with what we call a full tank of gas. Like they're born with calories to sustain them and energy to sustain them. And they don't need immense amounts of milk until the milk comes in. And a first-time mom, that's not for many days after birth. And so to remember that for millions of years, we have as a species have evolved without formula and without pumps, and babies have been able to pull in and drive in a healthy, robust supply in their moms by being so hungry at the breast. And that is a really crucial piece of the puzzle, letting the baby aggressively nurse and cluster feed those first few hours and moments and days to make the milk come in and to get the baby used to the breast. And while it can't always be avoided, the early introduction of bottle, when there's not a real medical need for it, can be have a devastating impact on future breastfeeding. So I say, of course, there are times we need to, but just remember that crying doesn't mean that you're not going to be making enough milk in a few days from now. And it doesn't mean that you're doing something harmful to your child. That babies are meant to be hungry, and your body's meant to respond to that. And most of the time it will. And if it's not, then ask for help.
Yeah. Thank you for those words of encouragement. And as I reflect on our hour together, I recognize that so much of what we talked about is kind of the pathology, if you will, around breastfeeding, right? Like low supply, like oversupply, what to do with if there's concerns about tongue tie, et cetera. But I'm sure, and that's the nature of your job, and that you are an expert and you do, I personally have referred to you some hard cases, but I'd love to end on a happy note. And of course, kind of in light of HIPAA confidentiality, share with what you feel comfortable with. But do you have any kind of success stories with any patient that you remember in particular that stands out for you, a moment that you're really proud of and really appreciate?
I think my favorite are the women who have a real tough time with their one child, let's say their firstborn, or maybe it's their second or thirdborn, oftentimes because they're given wrong advice. So they're really encouraged to distrust their own body. Maybe they're told they have flat nipples when really, to me, they look like very normal nipple anatomy. Or maybe they're told they have low supply when they weren't really given an adequate chance to, breastfeed. And maybe they had mastitis and then they were told to massage and apply heat and it got worse. So having someone who has an experience like that, encountering them in the thick of it and the worst of it, helping them through it, and maybe, it doesn't lead to a perfect outcome. They still had the mastitis and the abscess, or they still had a difficult time getting breastfeeding started because they weren't trusting their body to begin with. But then seeing them through their second pregnancy and doing counseling in the antepartum time period leading up to the birth of the second or third subsequent pregnancy, that is just really profound to have people come back and be like, wow, what a world of difference it makes to have support, to have someone I trust, and to have information that makes sense. And then to see it go flawlessly, not a problem whatsoever. And for them to just sometimes come in for a visit just to say thank you, they want to say hi and ask little questions that aren't at all about problems with them, but just to make sure it's all going well in there and it's just going wonderfully. And I think that flip, and of course, not to say that's at all just because of me. A lot of times the body can do things much better with subsequent pregnancies and deliveries, and a woman's trust in herself and confidence grows each time. But to see that process, that real natural physiologic process evolve for someone and change, and know that one tough experience doesn't mean it's always going to be this way.
Yeah. Yeah. I think what you alluded to is the continuity of care, right? That's one of the things about my practice that I love the most is it's such an honor to care for someone through those highs and lows and see them and cheerlead them on, knowing that, hey, you're going to get through this, and being able to see them on the other side, whether for you, it's like a subsequent pregnancy and where the feeding is going well. That's such a beautiful thing. And speaking of your practice, as we wrap up, do you want to tell us kind of about your practice, where you're located, what referrals you accept, et cetera?
Yeah. My practice is kind of, as mentioned before, it's breastfeeding medicine and breast surgical oncology. So I see the wide gamut of everything related to the breast, but a good majority of my practice is breastfeeding. I'm located in Greenbrae, which is a town in Marin County off the freeway, so very accessible to people who are in San Francisco, the East Bay, and North Bay. And I really accept, for the most part, any breastfeeding referrals. I try not to turn anyone away. Some people need one quick visit and some people need many, based on what they're coming in with. And I have a wonderful team of lactation consultants who work with me in my clinic, and we see people together typically. And we take all insurances for the most part, all major insurances, and we take Medi-Cal as well. So Medicaid.
As already alluded to multiple times during this episode, I have sent some of my own patients your way. And I know a lot of people in my OB/GYN department are so excited that we have you in our community. So if anyone who's listening, who's local, Dr. Rachel Yang is definitely a resource. And I thank you so much for your time. Even though I've heard some of these things before, I've actually learned more from you again. So I might just continue to force you to talk to me like every year so I can keep learning from you.
Me too.
You're such a resource, not only to myself and other clinicians, but I think more importantly, the patients that you get to serve, let alone whoever has had the honor of listening to this episode. I think, as you alluded to, there's so much more that we need to learn about breastfeeding and lactation health, but making sure that the information that we currently have is being offered to everyone as accessible as possible is a passion of mine. And so thank you for agreeing to be on as a guest. It's been a really, really great time with you.
It's been such a pleasure. Thank you for having me.
Thank you very much for listening to The Golden Hour, the podcast community where moms and moms-to-be can hear stories from other mothers and learn from top experts in pregnancy and postpartum care. If you enjoyed this episode, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, questions, or suggestions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Looking forward to seeing you in the next episode. Until then, stay golden.